Welcome to this video on breast cancer. I want to start off by saying that this video is scratching the surface of breast cancer, but it'll give you all the basic information you need to know as a medical student, and we'll go a little further into depth in terms of staging and treatment for residents. First, let's talk about the type of patients that get breast cancer. What are the risk factors? Things that cause greater exposure to estrogen. For example, patients that have had early menarche, let's say less than 10 years old, late menopause after 55 years old, nulliparty, and hormone replacement therapy. Another major risk factor is radiation. So think about those patients that receive radiation to the chest, like treatment of Hodgkin's lymphoma. Lastly, genetics, mainly BRCA1 or 2, the big ones you always hear about. These mutations increase the risk of breast and ovarian cancer. Now that we have talked about risk factors, how do we come across these patients? Hopefully, it is through the asymptomatic screen. Screening is a major source of debate for breast cancer. There is conflicting recommendations, and you should go by your institution's policy on their guidelines and recommendations. The two most common national recommendations are to start at age 50 and screen every 2 years, or to start at age 40 and screen every 1 year. Obviously, one is going to catch more breast cancer than the other, but in a national level, you should also consider the cost versus benefit ratio for doing this screening. Screening is done using ultrasound for younger patients, mammogram for most patients, and MRI for high-risk patients, such as strong family history or personal history of radiation to the chest. Some clinicians may disagree on this, but self-exams and clinical exams are often not helpful, and it is rare you will do one well enough that you are certain there's no abnormal masses. On an exam, don't pick self-exam. The second way breast cancer is diagnosed is from an identified breast lump. The last way to see if it is obviously cancer, with skin dimpling, fixed, firm axillary nodes, and the large fixed mass. What do you do to diagnose these patients? You get that mammogram and you go for the biopsy. There are 3 types of biopsies that can be performed: fine needle aspiration, excisional biopsy, and core needle biopsy. Fine needle aspiration is for younger women, less than 30 years old, where you feel confident it's just a cyst. An excisional biopsy is a choice when it's obviously cancer, and you just need to take the whole thing out. Lastly, the core needle biopsy is the most common biopsy used to diagnose breast cancer. It takes a larger piece of tissue and allows for a lot of stains to be done, and at the same time, it's breast conserving. So the special exception to mammography and biopsies is for the younger patients under 30 years old. It is unlikely that these patients have breast cancer, so you first start with reassurance. Book a follow-up appointment. Sometimes cysts arise during a younger patient's menstrual cycle and often go away on their own. So wait 2 or 3 cycles. If the mass doesn't go away or the patient wants something else to be done, then get an ultrasound. If the ultrasound shows a cyst, then you can aspirate using fine needle aspiration. If the ultrasound shows a mass, then you'll need to get diagnostic mammogram because it is concerning for cancer. If the patient has a cyst and you aspirate, there are 2 outcomes. The fluid is unremarkable or from infection. The cyst goes away, then you're in the clear. Provide the patient with reassurance and send them home. If the aspirate, however, is bloody, or if the cyst recurs after draining, then the patient will need to be further worked up with mammogram and biopsied. Now that we have diagnosed the patient, let's look towards treatment. The mainstay of treatment is the stage of the cancer. This is where we divert to more of a resident level education. However, medical students may want to stick around to learn more generalities and learn treatment drugs we use for patients with breast cancer. Let's talk about staging. Basically, staging depends on 2 things: the size of the mass and the number of nodes involved. The bigger the size, the more nodes involved, then the higher the staging. Remember the numbers 2 and 5 centimeters for size, and the numbers 0 and 4 for the number of nodes involved. So stage 1 is a mass less than 2 centimeters with 0 node involvement. Stage 2 can either be a mass less than 2 centimeters in size and 1 to 3 nodes involved, or a mass 2 to 5 centimeters in size with 0 and up to 3 node involvement. Stage 3 is when the mass is over 5 centimeters or when there is more than 4 nodes involved. If the mass is affixed to the chest, it's also stage 3. Stage 4 is where there's a distant metastasis, and most people usually know stage 4. We're going to stop this video here because the treatment of these stages gets a little complex, and the drugs we use for treatment have their own side effects that take time to cover. Thank you for watching this video, and be sure to look at my next video to learn the remainder of the basics of breast cancer. Remember that although these concepts are very theoretical to you, the diagnosis changes your patient's entire life. It's a beautiful day to save lives. Thank you for watching.